Hello, I'm Dr. Constance Dunlap. I am a psychiatrist and psychoanalyst in full-time practice in Washington, D.C. I'm also a member of the APA Assembly representing the Washington Psychiatric Society. I am here this morning with Dr. Jessica Isom. Dr. Isom, would you introduce yourself?
Sure. My name is Dr. Jessica Isom. I'm a graduating fourth-year resident at the Yale Department of Psychiatry. I am also a member of the Assembly as the Area 1 representative for resident fellow members. And I also hold two positions within the Department of Psychiatry. I'm one of the chief residents of diversity and inclusion and one of the current co-directors for the social justice and health equity curriculum.
Over the last couple of years, Dr. Isom, you and I have had an opportunity to work together in the Assembly. And what has grown from that is our ability to collaborate on addressing race and racism in medical education. And I want to ask you if you would say a little bit about the program that you and Dr. D'Souza and your colleagues are doing in the long-term care clinic in the Department of Psychiatry at Yale.
So we noticed that there wasn't really good role modeling for how to address race and racism in our clinical interactions with patients or with our supervisors. So what we tried to do was do an examination of the literature and see what we could find. And what we found was that there were a lot of resources out there that could inform the work that we were doing. But we wanted to also liaison with people who are already doing that work. So you yourself introduced a lot of the concepts that we relied on to think about how we could do it better. And fortunately, we work in a department that allows us to ask these kinds of questions of those who do our teaching. So we asked the question, we had the answer that we could do this sort of project, and we're able to do a research study that essentially asked of the supervisors and residents, what are your experiences around race and racism in your supervision sessions and in your work with patients? And we've gotten the answers, and the answers have shown us that there's a lot of work to do, and now we're working on sort of rolling out what those solutions might be for addressing this gap in the education.
Well, your program is very special because, as we know, one of the complaints, which actually goes back to an article that was written in December 1970 in the Journal of the American Psychiatric Association, authored by Dr. Billy Jones and four of his colleagues, and they described how race is mentioned in an intake, but then not much is done after that. And so that was written, as you know, 50 years ago, and so we've talked about how you've been able to make use of that because it's just as applicable today as it was yesterday.
Yes.
One of the other things that Dr. Jones and his colleagues talked about was the experience of the residents working with supervisors. And so I wanted to ask you, what experiences did you have, negative and positive, you and your colleagues, in working with the supervisors as they were helping you with your patients?
So I can talk about one of the first times that I brought race into the supervision room, and it was around a patient who had some difficulty interacting with me because she felt as a white woman that working with a black woman would be a burdensome experience for me. And in trying to talk about that with my supervisor, the conversation didn't quite go very well, and that I didn't feel like we paid a lot of attention to the really nuanced aspects of that. Funny enough, after this survey, I've had some more supervision sessions with this supervisor, and I think with that intervention, things have changed a bit because now there's more awareness about that. So I actually made a recommendation to read a book called White Fragility.
Oh, yes.
Why is it so hard for...
book, yes.
Yeah, and he read the book, actually, in the time between a session on Friday and the next Friday, and we talked about that in the following supervision session. And though we only have a few more sessions together, I feel like I've sort of planted a seed, and he's thinking about these things now as a white man and his relationship with racism. So that's sort of a positive outcome from having that conversation in the first place.
Yeah, that's a very fertile seed that has been planted. Considering the lack of experience, relative lack of experience that you and your cohort had with getting supervision around race, ethnicity, and really, you know, we're thinking of issues of difference. How would you say you all were affected by the reality is that your supervisors were not as experienced as you would have hoped for them to be? And the understanding that I have from looking at the literature is that the residents, trainees are taking the lead in addressing this. And I think it kind of reminds me of what's happening with social media. You have so much information, and so you're out there, you're out front, and so you know more. But one of the questions is, what has that been like? How has it affected you, and your colleagues mood-wise, and what feedback could you give to the supervisors, my colleagues?
Yeah, it's funny that you asked that question because it's actually an overwhelming experience and oftentimes requires a lot of processing with the people that are also doing the same work. So for example, if there's an intervention in a clinical setting where something was said that was inappropriate or there's a lesson that needs to be taught, we'll teach the lesson as the trainee and then recede into our office and actually process how that felt, to be in an environment that doesn't really role model in the way that it's supposed to. I think also it's really challenging as a trainee trying to become a psychiatrist or even in medical school trying to become a doctor and at the same time have to navigate these other areas as well. So I think while other colleagues are studying for the boards or studying to sort of provide really good patient care, I might be diving into a book about race, racism, implicit bias or these other topics, and it does feel like I'm sort of sacrificing some of my educational experience. So there's a tension there that makes it really difficult. And I think there's an anxiety also with also being the person expected to say things in these settings and being looked upon in that way.
Like an extra burden.
Yeah, it's really
extra
challenging.
Responsibility.
And I don't quite think that supervisors often recognize that psychological toll that it takes. I think you walk in and you're sort of the superhero to save the day and provide this information that they so desperately need, but they often don't see your humanity, that this is stressful, this is anxiety provoking, it's affecting your mood. We don't really talk about that. It's more so at times, give me what you can, and there's not necessarily reciprocity in what they offer you as far as like the support in those other ways.
Well, what you're describing, which is doing your own self-study, I must tell you, I believe that must be the experience of the African American, the ethnic minority in this country. I think about being in junior high school and reading Langston Hughes, James Baldwin, Gwendolyn Brooks. In other words, doing my own study outside of school. And that has carried through college, medical school, and even in residency and definitely psychoanalytic training, where psychoanalysts like Frantz Fanon, Frances Cress Welsing, even Dorothy Holmes. I mean, there are a number of people who, Charles Prudhomme, who was writing in the 30s. These people at that time were not included in the mainstream curriculum. Now fast forward, in speaking with Dr. Dennis, my understanding is that these authors are included. And that's just another example of the way that medicine and psychoanalysis has been functioning in parallel with the way the country functions, which is that we can ignore race and somehow consider it optional. And of course, with the work that we're doing, the goal is to help people to understand that this is a huge blind spot, and for it to be overlooked, it means that not only are we in our own training not getting what we need. It's not being processed. And of course it means that patients aren't getting it, and then you're experiencing what happens when the supervisees are not getting it. Any of you want to add anything to that?
Well, I'll say there's a way to respond to this critique that I think has actually happened in our program. For example, we have this third-year curriculum that hadn't really contained that much content around differences and how that operates in the dyad. I just went to a session where I was invited to because of this study, where they talked about difference, and the supervisor that leads the study actually had a pile of papers, probably 10 to 15 papers just on race, ethnicity, and other kinds of difference in psychotherapy. And she annotated it and sort of went through it and really was talking, and I was just the accessory. So I just sat there and sort of added things here and there as opposed to being the expert in the room.
Right.
And I feel like that's an example of how you notice your blind spot and then do something proactive about it in the moment. So she incorporated this since February, and she's doing it now. So not waiting until the next year or the next year. So
well, let me ask you this, because that's an extraordinary example. So let me ask you, you had mentioned that in the presentation that we just gave, that some of the supervisors said that, well, they were learning along with you. They probably did not know what to say. Now, you and I know that psychoanalytic concepts, for especially object relations, is a part of the core curriculum
Right.
for a psychiatry resident. So it's not possible to get out of residency without having some familiarity. So it's, you have even more feelings because in a sense what they're saying is they don't know, and I believe that reflects a disavowal
Yeah.
and a decision to not know, because I maintain with confidence that they do know, but something allows them to just kind of have it recede to the background.
And that there's so much to offer in what they know because they have that educational background.
Right,
If
exactly.
only it would be applied to the topics that are most uncomfortable to talk about.
Right,
So I
right.
absolutely agree.
And it's in that discomfort that growth occurs.
Yeah, yeah. So we're sitting in the room and they're saying, you're here to help us, like, figure this out. And we're like, well, you have all of the foundational knowledge to help us figure this out.
And some extra years too.
Yeah. So, yeah.
So let me ask you about, I want to ask you about whether you experienced any disparaging remarks, whether you personally experienced any disparaging remarks, and if so, how were they handled, and also whether or not any disparaging remarks were made about blacks, poor patients, obese patients, and or women, or any difference. And let me just say, just to be clear, we're talking about race as, we've been focusing on race as an example of difference, but we know that race is a placeholder for any kind of difference.
Right.
It's just that I tend to focus on race because racism and oppression is organized around a black-white axis in this country, and I believe that when people come to the country, they kind of get organized around that. And there's some who are going to identify with white because they want to avoid oppression, discrimination, and often they find out that it just doesn't work that way. But let me also just say this before you respond. I remember when I was a fourth-year resident, and I was seeing a patient in the quiet room because she was pregnant, psychotic, and I was picking her up because I was just returning to from neurology to a rotation, and the woman was had a diagnosis of bipolar disorder. She was in about 11 weeks pregnant, and so lithium was not considered an option, and so we were waiting to decide whether or not she would have ECT, and this woman responded to me with invectives and with language that I had never experienced. I was born in South Carolina, and family migrated to the north, and we returned. But what I realized, I had absolutely no preparation, and I think that sometimes the supervisors may not be aware of that. And so let me ask you, if you go back to my original question, were there incidents, and if so, how were they handled?
Yeah, I think it's changed over time because the department has changed over time. I remember intern year, I was working with a patient. I was the intern black female. There was an Asian male that was a medical student. And we walked into the room to greet them for morning rounds. And this white male said to us, it's not a race thing, it's not a gender thing, but I'd like to wait for the rest of the team to come. So my response to that was, a little bit taken aback. I didn't really say anything to him in the moment. I sort of said, okay, we can respect that, and walked away. And I shared it with my team, and I really didn't have any expectations for how they would respond. I actually think I made it into a joke. I think that's how low my expectations were at the time.
It can be adaptive, but also.
And we didn't address it. It was sort of like it wasn't like a conversation or a debrief.
Wow.
It was sort of like, I don't know, the humor must have worked, I guess, to diffuse it. Now as a PGY4, when these things happen, I've gone through some trainings in the department and also elsewhere that kind of have armed me with things to say, even myself. And I've seen other people model it, I think, as others have modeled it, sort of like a diffusion thing. So for example, there was a patient that's supposed to be admitted to the floor, and this patient identified as transgender. And one of the nurses was sort of answering a question as to what room this person would be in. And this was a female transgender patient. And the nurse said, well, it depends on kind of what they have down there. And that was a really, inappropriate comment, and obviously it's not in the policy.
Right.
I said, and a social worker said, well, that's actually not appropriate.
Right.
It doesn't matter what kind of reassignment they've had or not. It really is a matter of what's in the policy. And I think feeling emboldened to even say
Yes,
that
yes.
is based on having gone through a number of years navigating these scenarios, but also feeling like there are allies in the room that understand that that's not the way that you respond to this situation.
Right. And I
Yeah.
think this illustrates, because of our own experience, we have empathy and we are able to advocate for others in a very natural way, and we feel empowered to do so.
Yeah, yeah.
So let me ask you, I think this is a big question, what kinds of structural changes do you think are needed within the medical school environment and also you can speak to residency, to improve the curriculum so that this is brought to the center where it belongs? And by the way, that doesn't mean that, so a patient walks in a room and you just start talking about race. It's about how to address it when it is most relevant. So any thoughts about that?
I do. I have two thoughts of many, but two thoughts. One is that if we're thinking about the cause of health disparities, for example, being racism and not race, that forces us to have a different kind of conversation. And I think I recall from medical school that all of my presentations on chronic medical illness, risk factors included being black. And I remember sitting in the lecture hall and wondering what about my blackness means that I am somehow different from everyone else and I will have more diabetes, more heart attacks, more strokes, those sorts of things. And that was never explained to me. I actually accessed that information in public health school. We realized how inappropriate that teaching was.
Right.
I would say the second thing is ask ourselves when we write race in documentation, what meaning does that have?
Yes.
So we gave a presentation here at the annual meeting and we talked about that and the room paused. And not that we had an answer as far as where it kind of should go perfectly, but at least they paused and reflected, what does it mean when I write race in the chart? And we talked about instructing learners to write it in the social history or maybe in the formulation, but no one's teaching that either. So we kind of throw race at some point into the documentation and assume that it doesn't have a meaning, but it has a very rich, robust meaning, and not the meaning that we'd like it to have. So I think in the teaching, even acknowledging race has some kind of impact on how we're thinking about patients would be a start.